Welcome to Clinical Challenges in the Management of Complex Patients with Type 2 Diabetes mellitus, presented by Albert Einstein College of Medicine of Yeshiva University at Diabetes Series Live. Today is the second segment in this two-part educational series, and our first session of today's program is titled Glucose Control for Patients with Cardiovascular Risk Factors, the Role of Incretin-based Therapies with Dr. Mark Stolar. My name is Dr. Monica Peek, and I'm an assistant professor in the Division of General Internal Medicine at the University of Chicago and associate director of the Chicago Center for Diabetes Translation Research. Today's session is a live interactive program that allows us to take questions in real time throughout this presentation. I encourage you to send us your questions anytime during the program by typing them in the box located at the lower left-hand side of your screen. I'd now like to introduce our presenter, Dr. Mark Stolar, Associate Professor of Clinical Medicine, General Internal Medicine, and Geriatrics at the Northwestern University Feinberg School of Medicine. Welcome, Mark. I'll now hand the program over to you.
Thanks, Monica. Pleasure to be here. Welcome, everybody. Thanks for taking time out of your busy day to join us. And the whole concept of cardiovascular disease, cardiometabolic risk, and diabetes is the holy grail of treatment of diabetes. I think that every investigator, every pharmaceutical company is looking for ways that somehow we could find a magic bullet that would address both elevated blood sugar and cardiovascular risk. And to date, our studies really haven't shown us any benefit with treatment of diabetes. And it doesn't mean that treatment of diabetes doesn't improve cardiometabolic risk, but some of the models we've used to examine cardiovascular outcomes may not be exactly correct to answer that question. And so I think the key take-home from today is going to be, when you're treating diabetes, you're treating diabetes. When you're treating cardiometabolic risk, you're treating cardiometabolic risk. But to have a better understanding of the interplay of how our treatment might actually impact. And I think the incretin-based therapies are a good model for discussing potential benefits of therapy on cardiovascular outcomes. So that's where I'm going today. I'm going to turn these questions back to you to kind of see where our audience is, and then we'll get on with the program.
Great. So we're going to start with two anonymous audience polling questions. The first of which is, please rate your agreement with the following statement. When selecting an anti-hyperglycemic therapy for a patient with diabetes, I routinely consider its impact on the patient's cardiovascular risk status. A is agree completely, B, agree, C, agree somewhat, D, disagree, and E, disagree completely. So we'll take 1 second. Wonderful. So it looks like they're still coming in. All right, so everyone agreed with that statement, Mark. 48% agreed, no, there's still a little, one or two coming in. Okay, so everyone agreed. 50% agreed completely, 27% agreed, and 23% agreed somewhat. So again, no one disagreed with the comment, but there's some variability in the degree to which people actually agreed with that statement.
And so I think what we'll probe in our discussion, and we can certainly probe in the Q&A, is how many of those people who agreed were looking for cardiovascular benefit, and how many of the people who agreed were looking for cardiovascular safety.
Wonderful. All right.
Next question.
So this is our next, again, anonymous audience polling question. And the question is, how confident are you regarding your knowledge of incretin therapy and its potential impact on cardiovascular risk? A, very confident, B, confident, C, somewhat confident, and then D, not confident at all. So we'll take a second. All right. So only 3% of respondents were very confident. Oh, wait, we still have a few more people responding. Okay. 7% were very confident. 27, nope. There's still a few changes. I'm going to wait 1 more second.
It's Chicago. Votes change.
All right, so 6% very confident, 27% confident, 21% somewhat confident, and about half, or 45%, not confident at all in knowledge about incretin therapy and its potential impact on cardiovascular risk. So I think there's a lot of room for people to learn with your session today.
And actually, we'll be talking about 2 large studies that reported out in September, which will help give people confidence in understanding what these agents can or can't do.
Wonderful.
So let's get on with the program.
All right.
So we tended to view cardiovascular risk in diabetes as being this on and off phenomenon where, okay, you've got diabetes, now you have risk. But really, the cardiovascular continuum of patients with diabetes begins long before diabetes. And so this is a study from the Nurses' Health Study, which just looked at non-diabetics versus the incidence of cardiovascular disease before diabetes was diagnosed, after diabetes was diagnosed, and those women who entered the study at baseline. And obviously, those women who entered the study at baseline with diabetes had the highest risk. But in pre-diabetes, the relative risk was almost threefold increased. And that makes sense because the soil from which cardiovascular disease springs is not the elevated blood glucose, it's the insulin resistance and cardiometabolic risk. And so what it tells us is we can't look at our outcome trials and our diabetes therapies over a short term and say, aha, here's the impact on cardiovascular disease because it was going on for so much longer. And I think if you look at this continuum of diabetes, continuum of cardiovascular risk, continuum of complications in this slide, you can see that the hyperinsulinemia, the dyslipidemia, the hypertension, the endothelial dysfunction begins decades before diabetes is diagnosed. And so it's going to take time to modify that. And we might have to study these patients for 10 or 15 years to see the impact of disease that's already been present for 20 or 30. But if you just look at that slide and look at the right-hand side of the slide, and look at the complications of established diabetes, retinopathy, nephropathy, neuropathy, what's the unifying factor there? You can't reverse them. And you can't modify them easily. And the longer the patient has the complications, you can't modify them at all. Well, cardiovascular disease is no different. The longer it's established, the less modifiable it is. And in patients with pre-existing cardiovascular disease, it's going to be even more difficult to modify, especially when you're using agents that treat blood glucose and not so much insulin resistance and lipids. So I think that's why we've been looking for an answer and why it's been so hard to find one. So there are a couple studies which tell us that we can have an impact on cardiovascular disease treating diabetes. So there's one in type 1 diabetes, the EDIC trial. There's one, the UK PDS trial in type 2 diabetes. And these were long-term studies which examined the difference between tight control versus conventional control and looking at complications. But in both of those trials, they followed patients for 8 to 10 years afterwards and then compared outcomes. Right. And at the end of 8 to 10 years, as we'll see in the next slide, their control was no different, but their outcomes were different. So even though the two groups merged, the groups that had tight control had reduced cardiovascular risk. So there is benefit from long-term control. But we don't see that consistently. So in the VADT trial, for example, there wasn't a benefit in microvascular or macrovascular complications seen, with the exception of the subset of patients who had negative coronary calcium scores. The lowest disease burden, earliest in disease, did show a benefit, but it was a small subset. And that gets back to that concept of limited disease is modifiable, established disease is not easily modifiable. But these would suggest that there's a legacy effect, that there's a metabolic memory of the vasculature and of the tissues to hyperglycemia. And if you can reduce it, you may actually get benefit. So this just shows the big difference between the two groups in the EDIC trial, and it's the same in the type 2 diabetes trial. You could see that at the end of the study period, the 10 years, there was a big difference in glycemic control between the two groups, and yet when they followed them 10 years later, they were the same. But there was a persistent reduction, small, modest, only about 14%, reduction in cardiovascular outcomes. So there was a legacy that continued. And so we really need to look at atherosclerosis and cardiovascular risk as a lifelong disease. And then we have to modify the life, not modify, okay, I'm going to do this for 2 years and expect to see something happen. So why don't the other studies show this? Well, just like there's good memories in life, there's bad memories. There's a good legacy and there's a bad legacy. So in the VA trial, for example, those patients entered the trial with an A1C over 9. So instead of entering the trial with good metabolic memory, they're entering it with bad metabolic memory. So if you have patients who have had their disease for over 10 years, which is what the patients in the VA trial did, and their A1C is 9, you've got a whole lot of bad metabolic memory going on. And if you study those patients for 3 or 4 years, it's not likely you're going to see a benefit. You'd have to study them for almost an equal period of time of good control versus their bad control.